Welcome to the National Headache Foundation's Healthcare Professional Podcast Series. This episode is brought to you through a grant from MAP Pharmaceuticals. For this program, Dr. Robert Kaniecki from the University of Pittsburgh shares with us what's on the horizon for acute headache treatment. Now we go to the University of Pittsburgh and join Dr. Kaniecki.
Hello, I'm Robert Kaniecki, Director of the Headache Center, Chief of the Headache Division, and Assistant Professor of Neurology at the University of Pittsburgh. I'd like to spend a few minutes with you today sharing some important updates from the field of headache research. In this episode, we'd like to concentrate on acute migraine management. But before we get into the new drugs, I'd like to take a little bit of a look back. We've had the triptans available for 20 years, but we've learned lessons over the past 5 to 10 years of truly how to use them well, treat early, full doses, how to use the different formulations. We also have had nonsteroidals for decades. And we've learned important lessons of how well they do work in migraine. We have a combination of a nonsteroidal and a triptan, sumatriptan with naproxen. And in the spring of 2010, we'll have a new development, that being diclofenac in powdered form to be dissolved and then administered quickly to patients with acute migraine. So we're learning new ways of using these drugs that we've had it for some time now, and perhaps some new ways of administering these drugs. In addition to learning new tricks with old drugs, we've also now had exciting developments of new drugs working at receptors that had previously been unexplored. The CGRP antagonists are among the most exciting and perhaps the closest to market. Talcagipant, the first oral agent of its kind, has been studied and shown to be effective in phase 2 and phase 3 trials for acute migraine. These provide an opportunity to address migraine at the neuronal level while sparing the vascular level, therefore giving us an opportunity to treat patients who, one, perhaps didn't respond to the triptans, or two, perhaps who had triptan contraindications, vascular disease. Some of the intricacies and the final details need to be worked out, but these are clearly an exciting development for all of us treating migraine patients. In addition to the CGRP receptor, the vanilloid receptor, glutamate receptors, nitric oxide pathways, all are fertile areas for migraine research at both the preventive and the acute levels. In addition to new drugs working at new receptors, we have new delivery systems being developed for old drugs. Sumatriptan has been available in the needle delivery system since 1993 in the US, but in the past 6 months we have a needle-free version of injectable sumatriptan that has hit the market. And interestingly, that's the first needle-free delivery for any drug in any market at this point. In addition to injectable therapies, there are new novel inhaled ways of getting dihydroergotamine and prochlorperazine to the system. These are not typical nasal spray inhalers, but pulmonary inhalers coming to the migraine market and delivering old drugs in very rapid fashion at very high concentration, and with the data so far in a very effective manner. Finally, we have sumatriptan in patch form, sumatriptan in a new nasal spray form, a whole host of advances in the technologies of delivery systems that are very, very exciting and among the most productive areas of research in acute migraine management. In addition to new devices delivering older drugs, we have new devices perhaps working in new ways that may soon make their way to the market. The area of research in transcranial magnetic stimulation has spawned a treatment option, that being the transcranial pulse stimulator, which delivers a pair of pulses separated in time that has been shown to interrupt the cascade between aura and headache, deflecting perhaps the wave of spread cortical depression in a physical manner and preventing the development of the headache in patients who have aura predictably at the beginning of their attacks. I'd love to show you these devices, so why don't you join me in an exam room and I'll give you a close-up. All right, so let's take a look at some of these new devices. Let's start with the needle-free sumatriptan injection. This is the device, very simple. Basically, one takes the cap, snaps it off, then the device is loaded as such, single cock back, and then it can be delivered either to a pinch of skin in the abdomen or to the thigh. What we'll do is demonstrate it here on this squishy brain, and what you'll hear is an audible pop as the air canister is directly then generating the force that will propel the liquid through a laser drilled hole at the end of the device at such velocity that it pierces the skin and then delivers the medication to the system. So again, the first needle-free injection of any kind available here with sumatriptan. Next, we're going to talk about the inhaled versions of two old drugs. We mentioned both dihydroergotamine and prochlorperazine. This is the inhaler for dihydroergotamine. So this is a metered dose inhaler, multiple doses, basically loaded by bringing this bar up. It's now ready to go. It'll then be breath activated. You hear the click, and then the delivery of medication to the pulmonary alveoli for rapid absorption. That's the dihydroergotamine inhaler. This is the prochlorperazine inhaler. So there's no loading. This will also be breath activated, and the breath activation will trigger a heating filament, which will heat the medication rapidly within half a second into a vapor, then delivering the medication to the pulmonary alveoli as well. This device is a single dose unit, disposable. We may see multiple dose units that are a little bit larger than this, a little thicker and a little longer in the future. And then finally, the last device that I'm going to show you, this is the transcranial magnetic stimulator. The transcranial magnetic stimulator needs to be charged, so there's a button on here to charge this. This will deliver a pulse to the occipital area. So what we're going to do is to place this at the base of the skull. The theory behind this is that the electromagnetic pulse, the magnetic pulse that's generated, generates a wave across the cerebral cortex. And we understand aura as a wave of spreading cortical depression. So in essence, you have a stone dropped in the pond, the wave is going across the brain, and this is designed to disrupt it. You're throwing another stone to send ripples in the opposite direction to knock the wave down. Place it here. Several seconds of delivery of electromagnetic pulse. Then the device is recharged for the delivery of a second pulse. So we've looked at a number of different options for acute migraine. We've talked about new tricks with old drugs. We've talked about new drugs working at new receptors. We've talked about new devices, delivery systems with old drugs, and then finally new devices working in novel ways. It's an exciting time to be a migraine clinician with all these options available to us presently, and then a wealth of opportunities available for us in the future. So join me in looking towards the future that we can provide better care for our migraine patients. Thank you for your attention.
Thank you for joining us for this edition of the National Headache Foundation's podcast series. We look forward to bringing you further updates about the latest headache treatments in the near future. We'd like to also take this opportunity to thank MAP Pharmaceuticals for their support of this program. For more information from the National Headache Foundation, please visit www.headaches.org or call us directly at 1-888-643-5552.